She is currently an associate professor in the section of geriatrics within the Department of Medicine and Department of Community Health Sciences at the University of Calgary. Her work has focused on mental illness and neuropsychiatric symptoms in older adults or those with neurodegenerative disorder. She also examines the experiences of older adults living in supportive living and long-term care with frailty, concomitant mood disorders, and neuropsychiatric symptoms. So for the next 30 minutes, Dr. Goodarzi will present on helping older adults living in long-term care experiencing depression. We will then have 10 minutes for questions. Questions can be typed in the chat box. Questions and any technical support issues can also be emailed to the Knowledge Exchange team email, which is listed in the event invitation. So please join me in welcoming Dr. Zahra Goodarzi.
Thank you. All right, so let's just jump right in. So if you could just go ahead a couple of slides because she's done the land acknowledgement already. And yes, so we've taken all appropriate steps to ensure copyright has been adhered to and all citations have been taken account of. Next slide. And I don't really have anything to disclose. All of my funding is peer-reviewed independent research funding for research. I've had an honoraria for guideline creation. Next slide. Okay, so we're going to talk first about how common depression is, how we're going to look at detecting depression in persons living in long-term care and those with dementia. We'll look at how depression affects those persons, and then we'll talk a bit about treatment. Next slide. So we know that depression or depressive symptoms are very common in this population, and I've broken it into kind of a couple things here because there's some studies that look at depression as per the major criteria and some that look at what we would call clinically relevant depressive symptoms. So persons who have symptoms significant enough to affect them but may not meet all criteria within the DSM. And this sort of differs as we look at older adults. So the population in long-term care has a high proportion of persons experiencing depression, with upwards of 44% experiencing depression in existing literature. And similarly, so this amount of depression is quite high in persons with dementia, with at least 15% experiencing major depressive disorder. It's important to think about this in relation to the proportion of older adults in general. So we're talking about most older adults between 5 to 10% have major depression. So we are seeing a significant increase in the amount of depression that we see in persons living in long-term care or those with dementia. Next slide. We did a study looking specifically at the prevalence of depression in Alberta long-term care through translating research in long-term care. And we found that 40% of persons had depressive symptoms. And when looking at those who also had cognitive impairment, it was about 35%. So similar to other international research. And the overall, those with cognitive impairment in long-term care have an increased odds of depressive symptoms at about 2. So a higher likelihood than those without cognitive impairment. Next slide. So overall, persons with dementia are about 2 to 2.6 times more likely to experience depression, and those in long-term care, certainly we have a high proportion with cognitive impairment, about 80%, and those in long-term care in general are at high risk of depression. So certainly a big problem experienced by those persons in long-term care and those with dementia. Next slide. So when we talk about why this is problematic, really, I mean, there's lots of factors, but here's some of the key ones. Is depression leads to reduced quality of life for these individuals, worsened memory for those both with and without dementia, worsened physical function, increased risk of mortality, and an increased risk of caregiver burden and depression in the caregiver as well. So really, we're seeing a huge impact of depression on the individual, but also those around them. And so it really behooves us to have an approach to depression in long-term care that is really proactive. Next slide. The challenge is, of course, as many places, we have scarce resources in long-term care when it comes specifically to mental health, but also amongst all the things that long-term care has to deal with, and the providers there's a lot to handle. But we also want to look at how we can do this in a timely and accurate way, and those two things are kind of at odds with each other. Next slide. The other issue here is when we're talking about persons who have dementia, there are overlapping symptoms between depression and dementia. There's overlapping symptoms when we look at depression and other neuropsychiatric symptoms, such as apathy. Persons with dementia may have challenges articulating their symptoms, whether it's due to speech issues, memory issues. There can be cultural differences and stigma around mental illness, so people don't report their symptoms. There can also be sort of societal stigma, accepting that depression might be quote unquote normal. And the reliance on the caregiver report or care partner report can sometimes also be challenging for an individual, especially those of us when we're trying to understand if the individual is depressed, as they may also have a different interpretation of the symptoms. Next slide. One of the challenges there, so when relying on caregiver report, is sometimes a care partner who's more burdened or more stressed or more anxious themselves is more likely to report that the individual is depressed or experiencing other types of behaviors. So it's really important that we have tools that can help us in long-term care or with those with dementia to accurately identify the symptoms that they have. Next slide. And because of all the challenges in differentiating depression from other conditions, that's where we want to look at tools. So we've done a couple systematic reviews that help us to look at detection tools or questionnaires that can help us to really differentiate between them. So one study we did, we looked at depression tools within the long-term care population in general. And there were two tools to mention here. The first is the geriatric depression scale, the 15-item version, at a cutoff, sorry, there's a typo there, cutoff of 6. It had a sensitivity of 73%. So that's not the greatest accuracy, and there was a lot of heterogeneity across those studies. However, if we looked at the Cornell scale for depression and dementia, there was a higher range of sensitivity with between 67, but more studies in the 90%, showing a little bit more sensitivity. And the reason I'm focusing on sensitivity is a tool that is high in sensitivity will mean we don't miss too many cases of depression. Next slide. When we focus solely on studies that include populations with only persons living with dementia, the Cornell scale was the most accurate tool. Again, at a cutoff of 6. Across 10 studies, it had a sensitivity of 91%. So that means really sensitive. We're going to pick up people with symptoms. We're not likely to miss patients with depression. We might have some false positives, but that can be caught later on. There is also a 4-item version that had some reasonable sensitivity at around 81%. The challenge with this tool is often in the literature it's reported to take 20 to 30 minutes. I, in practice, don't find that it actually takes that long. The reason, that they do find in studies that it takes long is because often you're asking questions between the caregiver as well as the patient. Next slide. Sorry. And I think I have the tool. Oh, sorry. Okay. That's okay. And so that can take a little bit more time. So either way, when we're choosing a tool for long-term care, we want to think of the location that we're working, the goal of that. We want to think about focused case findings. So we want to be sensitive in the tool. And if a person is positive or they score highly on a tool, that tool alone does not mean they have depression. It just means that there's that high risk the person has depression. There needs to be a confirmatory interview by a provider and potential workup for causes of depression. Next slide. Yeah, this is the one. So this is what the Cornell scale for depression and dementia looks like. So you can see here there's quite a few questions. I think what's really good about this is, like I said, you're asking questions between the person as well as the potential care partners. They're also asking questions around suicidality and some of the functional symptoms. So not just the mood symptoms, but also changes, for example, in early morning waking up, lack of energy, weight loss, appetite change, etc. etc. Like I said, I don't find in practice it takes me that long. I would say more along the lines of 10 to 15 minutes when I ask questions between the care partner or caregiver and the person living with dementia. And I do find that it is quite good at detecting those persons. Like I said, there was a 4-item version that had 1 study testing in long-term care. And so hopefully we'll have future research that will help us to validate shorter versions. Next slide. So once we have a person who's identified as high risk of depression on one of those tools, as I mentioned, we would then have a provider, whether that's a physician, nurse practitioner, nurse specialist, etc., do more of a confirmatory interview to ascertain that yes, in fact, we do think it is depression. So like I said, we don't make a diagnosis based on tool alone. And there should be a workup as to potential causes. So considering other factors. So for example, we want to think about things like grief, medications, recent illness, recent hospitalization, some of those factors that could contribute to an acute change in mood that might not signal a longer standing depressive disorder. But in those where we have confirmed that we do believe it is depressive disorder or significant depression symptoms that warrant therapy, we do want to move forward to consideration of treatment. I can talk a little bit more about workup later on if we want, but I wanted to spend a bit of time on the treatment side because this is often where we have a lot of questions. So we see a lot of variation in practice, available resources, and evidence for how to treat depression for those living in long-term care and with dementia. And that's really frustrating, certainly for all of us as providers and certainly for our patients and their loved ones, because it leads to a lot of variation in what's provided or available for care. And I know certainly a lot of us feel a little bit lost when it comes to managing some of these neuropsychiatric symptoms because often, of course, they overlap or they can be quite severe. Next slide. So there's been 2 systematic reviews that we've looked at. One is just underway of being published that looks at all available therapies for treating depression in persons living in long-term care. And then we did another one looking at all available therapies to treat persons with dementia. So we'll start with talking about that, which was focused on long-term care. Next slide. So this was a systematic review. So we've looked at all available literature, both published and in the gray literature. We looked at many, many abstracts, but we were able to look at 147 studies, which is great. There were 31 different treatments studied, and these were all included in what's called a network meta-analysis. That's just a specific type of synthesis analysis that allows us to compare all treatments to each other as long as they've been compared to a similar comparator group, such as usual care. This is a really powerful type of analysis because it often helps us to rank what the most efficacious interventions are. So in this particular study, the most common comparator group was usual care and across 104 studies. And then other common interventions were those looking at socialization interventions, 33 studies, exercise in 22 studies, and there were 6 treatments with more than 10 studies that evaluated the efficacy of the treatment, so we could look at the analysis of that. What I really want to draw your attention to here, though, is only 16 studies looked at medications, and the bulk of studies actually looked at non-drug interventions, which I, as a geriatrician, brings me joy that we have non-drug options to help manage persons. And so, like you said, you can see here that we have group reminiscence, multi-component, and exercise were really commonly studied. Next slide. In this particular study, we identified that the most effective treatment was actually horticulture, so working with plants. It was the highest reduction in depressive symptoms as measured by a depressive symptom tool. The second most effective was cognitive behavioral therapy, followed by that was animal therapy, and then group reminiscence therapy, multi-component strategies. These will be strategies that typically look at lots of different things. So often it's exercise and socialization and animal and music, like kind of a combination. Followed by that was exercise and then socialization. And so when we look at this, we want to think about what the proportion of depression reduction was. So horticulture was the most effective in reducing depression. And the second greatest reduction in depressive symptoms was the cognitive behavioral therapy at reducing symptoms around 30 to 40%. So we're certainly seeing a significant decrease in symptoms of depression in people who are receiving these therapies. Cognitive behavioral therapies is a series of different therapies that are directed towards treating mood disorders, and they're used in the general population as well, and they can certainly be quite effective. Next slide. Studies of antidepressants, like I said earlier, there was few drug studies. So antidepressants didn't really rank very high in our treatment analyses in this particular study because there was just so few studies and the studies were small. And then the studies that were there were medications that we actually typically don't recommend anymore, like tricyclic antidepressants. So overall, when it comes to the drug therapies, we need more high quality trials to understand what their role could be. Next slide. Now, if we solely focus on studies that only include populations with persons with dementia, next slide, this was a separate review that was done. Like I said, the inclusion criteria had to be the population had dementia, but within this, 101 studies were done in long-term care. So this was a massive review. It was over 28,000 persons with dementia would have been across all studies, the mean age about 70. Most of the dementia pathologies were mixed or Alzheimer's pathology, although certainly this was poorly reported in included studies, which is generally upsetting. Most had mild to moderate dementia symptoms, or they didn't say the severity of dementia. And like I said, a large proportion were studies done in long-term care. Next slide. So this is, I just put this up here not to overwhelm us all, but this is what I mean when I say network meta-analysis. So this like big blob on the right is what the UC is usual care. So this is where if we, for example, look at the one right above it on that thick line, REM, that's reminiscence therapy. So that big blob is showing how many patients received usual care. That thick line is showing you how many studies looked at the comparison between usual care and reminiscence therapy. And then all of those cross connections are showing all the connections between the different comparator groups that were done in order to do the subsequent analysis. So I only show you this to show you that there was many, many, many different treatments and treatment combinations that were done that we could look at for this study. Next slide. So to give you a nice visual way of looking at this, so the percent here is the percent probability that an intervention will decrease depressive symptoms in a clinically meaningful way for persons with dementia. In this particular figure I'm showing you, all interventions are compared to usual care. So the probability that the intervention will reduce depression. So massage and touch therapy has 100% probability that the symptoms will reduce. The combination of exercise, social interaction, and cognitive stimulation effective. Cognitive stimulation in those who are on cholinesterase inhibitors was also effective. Cognitive stimulation on its own was effective. The involvement of an occupational therapist was effective, and that was around adjusting the environment. Reminiscence therapy was effective, and the use of multidisciplinary care teams. Next slide. In this last one, this is the probability the intervention, again, will decrease depression. This was when they looked at pairwise, so this is just comparing the intervention to usual care, not to all other therapies, but the combination of psychotherapy or cognitive behavioral therapy, reminiscence, and modification of the environment is effective, as is animal therapy and exercise. Next slide. When we looked at just those living in long-term care, we did see the efficacious interventions similar to those in the overall population, including animal therapy, music therapy, occupational therapy, reminiscence therapy, and social interaction. Again, these numbers just showed the proportion reduction in symptoms. Next slide. So I wanted to just focus on what that means, because often when I say massage therapy, people are like, well, how are we going to get massage therapists into long-term care? That can be really difficult. A lot of these studies really looked at very simple massage or touch therapy. So gentle, non-medical, non-care provision touch. Like this is not, you're helping them get dressed. This is, I'm holding their hand, gentle shoulder rub, like gentle hand massage, kind of like the picture here. Very simple, non-medical touch was a big component of some of these studies. Like I said, psychotherapy or cognitive behavioral therapies were demonstrated to be effective. This is important because often persons with dementia are excluded from a lot of cognitive behavioral therapies because the perception is that that won't be effective, or they won't be able to carry over their learnings between sessions. But this does show that there is some efficacy here. Now, those therapies were specific to persons with dementia, but that's great. Like it still shows improvement. Modifying the environment is effective. Animal therapy, reminiscence therapy, and this is really focused on that person's individual personhood and past. Music therapy and occupational therapy, which is certainly related to environmental modification. Next slide. So this was just to really summarize some of the interventions we've talked about and really bring them to your attention. So cognitive stimulation, this is actually a structured therapy, very commonly done in the UK, several sessions per week for a defined number of hours. And it often combines a lot of the things that we talk about in these individual interventions. So often the tasks start with orientation exercise, then focused reminiscence, art therapy, games, really engaging the person's cognition. Like you said before, environmental modification is really key. Really want to highlight that exercise is an effective intervention, and this is any active engagement in aerobic resistance or balance training. And then multidisciplinary care. So this is the care plan developed by more than one care provider. So that's physician plus nurses, occupational therapists, specialists, etc. Next slide. And then lastly, really highlighting social interaction. So this is, again, non-medical social interaction. So interactions with caregivers in the facility, family, friends, that goes beyond the provision of usual care. Reminiscence, I want to really highlight as something that is any of us could do, is reminding them about their past, about their family, about who they are. And of course, animal therapy is pretty self-explanatory. With the cognitive behavioral therapies, one of the ones that was most effective listed up there was around validation. So validating the person's feelings and frustration and helping them to come up with strategies to mitigate the emotions during those times can be really effective. Okay, so we've talked about lots of non-drug interventions. We've talked about successful tools. Next slide. Why don't these things always happen? And certainly that can be a frustration that we all have. Next slide. So we did a study looking at barriers. This was largely in persons with dementia. We were trying to understand what the barriers were to managing depression in these persons. And one of the big challenges here is that there is variation in diagnostic criteria, tools, the types of dementia vary, the individual's ability to convey symptoms can be challenging. A lot of the things we mentioned earlier. Next slide. There was also a lot of challenges around people understanding the benefit or utility of using detection tools and concerns that those are perhaps not accurate. However, there was a lot of positive thoughts from patients or caregivers that these tools helped them to identify symptoms that they could then discuss with their healthcare provider. Next slide. Healthcare providers worried about the accuracy of tools and how they could fit them in their day, which is certainly a challenge. And of course, if a tool takes, a longer period of time to do, can be more and more challenging. Next slide. And there was also a perception that there was a lack of available training and confidence in the use of these tools, and that sometimes patients get very frustrated when they have to receive multiple tools. And importantly, a lot of these tools are available in English and some languages, but they may not be adapted to all cultural scenarios or languages, which is certainly a missing piece. Next slide. And just for time, let's skip this one. So when it comes to management, really a lot of perceptions were that prescribing is easier, right? Prescribing a medication is less labor intensive. Access to non-drug interventions can be very difficult, especially in long-term care. Waiting time for services is high. People perceive perhaps they might not be effective, or stigma might prevent people from accessing non-medication interventions because they don't want to be seen doing them. Cost, of course, can be prohibitive, and it can be difficult to advocate for some of these. And sometimes symptoms of dementia or other medical conditions can preclude a person doing things like exercise or cognitive behavioral therapy if they're dealing with more severe illness. Next slide. So there's recent guidelines, next slide, that have just come out in reference to managing symptoms in persons with dementia. And these include lots of behavioral and psychological symptoms. Next slide. I'll just highlight those that talk about depression. So they recommend the use of the National Institute of Mental Health's depression and Alzheimer's disease criteria. I only draw your attention to this because it's not the typical criteria. It's a little less focused on concentration and memory for obvious reasons. So the bar to diagnose a person with dementia is a little bit lower than it would be in the average population. Next slide. There was a recommendation to use the Cornell scale for those in clinics or in long-term care based on the evidence I provided to you earlier. Next slide. And then when talking about the management, a lot of these recommendations were based on the reviews I presented to you. They did recommend that they could consider the use of robotic pets, cognitive stimulation therapy. Next slide. Massage and touch therapy, physical exercise, and this is across community and long-term care settings. Next slide. That reminiscence therapy is effective, as is occupational therapy. Next slide. And that home problem-based therapy, behavioral therapies, and cognitive behavioral therapies can be considered. Now, there was a suggestion for those with more moderate to severe depression that has not responded to psychosocial or non-drug interventions that antidepressants or medications be considered. And certainly this is an important part of our management strategy. As I mentioned earlier, we don't have a lot of studies here, but that's largely because either those that existed are smaller, lower quality studies, and a lot of studies excluded persons with moderate to severe depression. You can imagine ethics of a trial. If a person has more severe depression or suicidality, they're often excluded from the trial. So my push on the non-drug interventions is not to say we should not be using medications to manage mood, is that we should be considering those as our first line. But if persons have more moderate to severe symptoms, we really should be looking to medication as well as the non-drug interventions, as they can certainly work together. Next slide. So by way of conclusion, I just wanted to kind of bring this all back together. So we really want to house this within the patient or resident's values, beliefs, and needs, as well as those of their decision makers and care partners. The use of a questionnaire to explore depressive symptoms can enable us as providers to have a more accurate understanding of their symptoms. It can also help persons and their care partners to express their symptoms and also attribute their symptoms. So sometimes patients and care partners may not realize that they're experiencing depression because, like I said, the symptoms overlap with dementia, or they might think it's normal for aging. When we do a tool, it is important that that tool is confirmed by an interview so that, like I said, the diagnosis is not solely being made based on a tool, that the healthcare provider then examines for contributing issues and addresses those. A really big one in long-term care would be pain or other symptoms from a condition like shortness of breath or challenges with gut health. All patients with depressive symptoms should be receiving non-drug therapies. And if a person has more severe symptoms, early pharmacologic therapy should be considered, but that doesn't negate receiving non-drug therapies. And for those who have severe, complex, refractory, challenging, unclear symptoms, really, it's very appropriate to talk to either geriatric psychiatry or geriatrics or care of the elderly or whoever is available at your site to help address and confirm what is is going on, and better off to check in earlier around some of these things if we're concerned. There are newer therapies being looked at, such as transcranial magnetic stimulation, to see if that could be effective for this population without having the same memory effects as ECT. But we'll have to kind of stay tuned for some of those studies, as again, of course, there's accessibility issues with that. So that's, I think, all I had for today. I wanted to make sure we had lots of time for questions and comments and all that good stuff. Thank you.
Thank you so much, Dr. Zahra. That was a very great presentation. So we now have around 10 minutes for questions. So if you have a question, please type them in the Q&A chat box. If you would prefer, you can also email your questions to the amh.knowledgeexchange@hs.ca email. This was also highlighted in our event invite. I'll just dive right into questions now. I can see we have a bit of questions already, so I will just start. The first question is, do you have any suggestions on how CBT can be accessed for long-term care residents?
Yeah, absolutely a huge issue. And I wish it was more accessible, which I obviously realize is not an answer. But I would be really looking towards your social workers and your available psychiatry teams as to what could be provided via those services. As far as I'm aware, when I've looked in the past for residents, I haven't found a lot of psychologists that go to long-term care, but there are a lot that also do virtual support. So I've had some patients access psychologists that way. Of course, maybe with some assistance for Zoom and whatnot, and that's been useful. Those are typically persons with more mild cognitive issues or no cognitive issues when they're using Zoom, but it can be an effective strategy. There are some studies going on looking at how we can better roll that out in long-term care, as I think it's certainly a service gap.
Okay, well, thank you. I'll dive into the next question. The next question is about the pets you mentioned during your suggestions. The question is, what about a real pet, like a long-term care cat? Are there any studies looking into this?
Yeah, like a in-house pet. Yeah, so a lot of the studies looked at like animal therapy as an intervention. So that's like, the trained cats and dogs, rabbits, etc. coming in. I think that any animal therapy is useful. So if there is a facility animal, I think that would be also very effective. I think I also think about a lot of these non-drug therapies as things that would make all of us happy, right? Like a lot of us have had pets in our life or enjoyed having pets in our lives, and you can see how that could bring people joy, especially when they might not be able to have their own pet. So I think that would be effective. There's also a lot of talk around robotic pets or like stuffed animals. There's, a bit of varying evidence there. Like I said, the robotic pets have a bit more evidence. Challenges with robotic pets, though, are largely around cost and then antimicrobial decontamination procedures. Although, as I understand, they all have a product to do that with. It is a little bit more expensive. And then also the other issue with pet therapy, just to highlight this, it really depends on the pet. I recall seeing a patient in long-term care when I was a fellow, a trainee, and she would become agitated once a week during pet therapy. And she had a significant phobia of dogs, and we didn't realize. And so, it is really individual to the person. Some of the pet therapy I've seen includes things like alpacas, the robot seal, and I really think it's really interesting with some of those different animals, because a lot of people don't have preformed ideas about alpacas. So sometimes those more unusual animals can actually be an interesting type of therapy. And if you want to smile, you should look up the alpaca pet therapy in long-term care, because they have tiny little hats and it's quite happy.
Yeah, the alpaca sounds really interesting. I would just
because they're like tall, and you can hug an alpaca, and like you can feed an alpaca like a whole apple. Anyways, it brings me joy to watch the video.
Okay, thank you. I'll just dive into the next question. Yep. So the next question says, what about the LTCF assessment and the depression rating scale? That is an output of the assessment.
Yeah, I was surprised when we did the study on depression scales in long-term care. We were only looking for studies that looked at that at any scale validated against a reference standard, meaning like a clinician interview or like criterion, and we couldn't find a study that really validated the DRS against that type of comparator. So I can't tell you, like there wasn't enough evidence to suggest that it was the best. The sensitivity was lower. And if you look at that scale, I think the challenge with the items on that scale is they're picking up distress in general, and a person who's depressed can be distressed, a person in pain. So I think you're picking up symptoms that could be attributed to depression, but it's not solely depression. I think that's the challenge with that scale.
Okay, sounds good. The next question is, what is the role of the traditional mental health therapist and talk therapy for those patients with dementia as a concurrent disorder with depression?
I think there is a role for that, and that's the key thing I would say. I think often in a lot of therapies, and this goes outside of depression, people with like rehab as well, people with dementia are excluded because there's, what if they don't retain it? What if they do retain it, right? What if they actually retain it and they improve? And there's lots of studies showing that they do in this. It does have to be tailored to the individual, of course. There does have to be some consideration. And after several sessions, perhaps that individual's cognition is too severe, and that's okay. You haven't really lost a lot. I often say to patients and caregivers, the worst thing that can happen in therapy is maybe you just don't like the person you're talking to, right? There's not usually that many side effects, right? Versus a medication or something else that can have more severe side effects. So I think there's a huge role, and I see here some notes around psychologists attached to sites, and I think that's really immensely useful for people as they live in long-term care and help to adapt to those situations.
Yeah, thank you. I'll just go to the next question. It says, are there challenges for older adults in retaining therapy content and information that is provided during therapy? Like, for example, the CBT for depression for those who have dementia?
Yeah, absolutely there can be, but this is where I was meaning like those types of therapies can really be adapted. So like validation therapy, for example, you might be looking at validating that person's emotions in the moment, and it's that sensation that can be effective. And like I said, for sure, I've sent persons for CBT and it maybe hasn't been as effective as it could have been if they had more recall. But if there's any benefit, I would argue that it's worthwhile. This is certainly where also having more group activities, of course, takes advantage of the therapist's time across a multitude of individuals. And so there was that few studies that looked at group reminiscence therapy as an intervention. I know that's not quite CBT, but as an example, you could be doing kind of sometimes maybe more of a group intervention that could take advantage of that person's time, but also be really helpful across the team, and then is also a social interaction for these people.
Thank you. So the next question I have is there a study looking at rural compared to urban residents?
Yeah. Sorry, rural compared to
urban residents.
Urban?
Yeah.
You know what? I don't think I can think of one that does it that way. There would have been rural studies included, but I don't believe we had enough to separate them out. But it's a good question.
Yeah, okay. Then we can just go to the next one. It says, is the CSDD sensitive to show post-intervention change in score?
Such a good question. There's not a lot of studies yet that have shown that, but I do think that's an important aspect. In fact, a lot of the depression tools are not validated to respond to treatment. However, I would encourage you to look at, behavior mapping or behavior change. Goal-oriented type behavior change tools can also be a way of monitoring the relevant symptoms that we're hoping would improve. And there's a BMJ paper about that. I can see if I can find it quick.
This question also has a follow-up question, which is, what duration of intervention is needed to show any changes in depression?
That's a really good question too. You all have excellent questions. So the it's a very wide range in study interventions here. So some of them are, brief 4-week interventions, and some are, a year or more. So, I would really think for these symptoms, we're probably going to be needing things in an ongoing fashion would be the best, right? If there's ongoing access to cognitive stimulation exercise, animal therapy, like that's going to be the most effective. But if we're talking about brief interventions with like cognitive behavioral therapy, I would suspect it's going to need to be at least 10 weeks or so. But like it's like I said, it's a bit nuanced.
Okay. This says, the next question says, psychology services are not covered by healthcare. If CBT is one of the most effective therapies, are you doing any advocacy to have it covered by LTC residents?
Excellent question. First step was having these guidelines completed, and they were like just put out this month. I think the more things are recommended in guidelines such as this, and that's a panel nationally of experts, was reviewed by persons with lived experience, etc. That helps us to put a benchmark in place by which we can then judge policy. So step one was making sure we have robust guidelines so that we can then hopefully inform policy. So ideally, yes, it just is a multi-phase plan.
Okay, this will be our last question for today. It says, I was told that with new residents, like resident new to LTC or SL4, have an adjustment period of about 3 months to get used to their new surroundings. Do residents get assessed in those first 3 months?
Do residents, sorry, what was that last part?
Do residents get assessed in those first 3 months?
Well, I think they would be. So yes, you absolutely can expect an adjustment period, of course. For some people, that can be really presenting like grief, right? Grief for the loss of their home and what they expected their retirement to look like. And that adjustment period is very normal. And it might not be depression, but it might be depressive symptoms, right? Or like I said, grief or bereavement. It certainly would warrant participation in non-drug interventions, I think, to help them to adjust. But if those symptoms are persisting on repeat assessments or concerns by the caregivers, the unit staff, etc., that's when I would start to look at that more diagnostic piece, right? But I'm pretty sure they would have and I think somebody just posted in the chat, I'm pretty sure they would have an inter-eye within the first quarter. So I think so. Yep.
Okay, thank you. Okay, so that's all the time we have today for questions. Thank you, Dr. Zahra, for the wonderful presentation. We really appreciate you sharing your work with us. If you have remaining questions for our presenter, she left her email at the end of the presentation slide. So, if you want to just pop it up again, just at the end of the slides, and so you can email your questions directly to her. Lastly, I just want to say thank you to everyone for attending. An email will be sent shortly to you with survey and information on where to find the recording. The recording will be posted on our website, and this will be sent to everybody after the presentation. We also hope to see you back for our next Launch and Learn in May, which will focus on the evaluation done on the mental health and suicide awareness program called the Community Helpers Program. And we will provide you more information on that event soon. So also be sure to subscribe to our event notices. And that's all for today. Take care, everyone.